Good afternoon. My name is Melissa Russo, and I am a maternal-fetal medicine specialist or a high-risk obstetrician and also a clinical geneticist. And today I'm going to be talking about pregnancy in women with Ehlers-Danlos syndrome. Today we're going to be discussing pregnancy's effects on a connective tissue disorder and the risks associated in pregnancy. We're also going to talk about things that you want to think about if you're considering having a baby, and then give you guys tools and resources to help you and help your healthcare provider so you can have a safe pregnancy. So if you're thinking about getting pregnant, I think with Ehlers-Danlos syndrome, really there's not one recommendation. Everybody is different, and I think that's an important thing to consider when you're thinking about having a pregnancy. One of the most common questions that I get as a provider is it safe for me to have a pregnancy? And I think really it's a very individualized decision, and that's something that you have to have in a one-on-one discussion with your doctor or your provider to figure out what is really the right thing for you. There's lots of ways to become a parent. If you want to have a child, you can have a pregnancy. Some people have problems with infertility, or they want to do genetic testing or put that embryo in another person, and they do a process called in vitro fertilization. Sometimes women choose to have another person carry their pregnancy, or they carry a pregnancy with someone else's eggs. Adoption is also an option to become a parent, and some people choose to not have children and really just are parents for plants or pets. And really, it's a very individualized decision, again, as to what you choose to do. Talking about Ehlers-Danlos syndrome, there's really a range of different types of disorders, and right now we know that there's 13 different types, and for each type, there's actually a variability in that clinical presentation, where some people can be very severe with their symptoms and others can be mild. Diagnosis is mainly based on history and exam findings, and in some cases there are genetic testing to complement that. So with Ehlers-Danlos syndrome, connective tissue disorders involve the skin, ligaments, bones, and blood vessels. And the connective tissues are an extensive extracellular matrix and framework with collagen and elastin that really provides strength and elasticity to our underlying structures in the body. The main things that can cause problems in pregnancy are that people have flexible loose joints, fragile skin, and they can have chronic musculoskeletal pain. Other symptoms are some people with Ehlers-Danlos syndrome can have POTS syndrome or postural tachycardia syndrome. Some people can have gastrointestinal issues at baseline, and those can get worse during pregnancy. And in some women, they can have cardiovascular problems that can then be exacerbated or worse during pregnancy. The main things we see are mitral valve prolapse, aortic aneurysm, and sometimes this can result in an aortic dissection or a tear in the aortic wall. So why is pregnancy a higher risk time for some of these problems? So we're going to discuss some of that right now. So there's changes in the cardiovascular system where in the third trimester there can be changes in the heart rate and the stroke volume, and there's more blood pumping around the body, and all of these things can put more stress on the blood vessels. Hormones change during pregnancy, especially estrogen and progesterone go up, which we'll talk about more in a second. Another hormone that changes is relaxin, which makes all of the joints a little bit looser. And this is important so that a baby is able to get through the birth canal, but this can also result in problems for women who already have joint instability. In terms of gastrointestinal changes, that increase in progesterone can cause issues where there is decreased GI motility, and also can relax some of the sphincters, which leads to worse reflux or heartburn. And also the uterus pushing up on all of the intestines and the stomach can cause crowding and cause more discomfort during pregnancy. Additionally, in the lower right corner, you can see that the center of gravity changes. And this can affect people's balance. And for women that already have some joint instability or sometimes pain or weakness, this can put them at increased risk for falls during pregnancy. And so this is important to consider during your care in pregnancy. So before we move on to talk about pregnancy, I think it's important just to talk about infertility, or the inability to get pregnant. The definition of this is if you've been trying to have a baby for a year and you haven't been successful. And that's when women start to go seeing some type of reproductive endocrinology specialist potentially to help with infertility. So with infertility, before we start talking about pregnancy, infertility can be an issue for women with Ehlers-Danlos syndrome. There was a survey done by the National Ehlers-Danlos Foundation, and they found that about 44% of women had issues with infertility. The definition of infertility is if you've been attempting to get pregnant for a year and have been unsuccessful, and that's when women will start seeking out specialists in reproductive endocrinology to sometimes help them with getting pregnant. If we look at the most common types of Ehlers-Danlos syndrome, this survey was done in types 1, 2, 3, and 4. They found that over 44% of them had trouble getting pregnant. The main reasons that were cited were polycystic ovarian syndrome, endometriosis, where you can have uterine tissue somewhere else in the body, and then in 30% there was no explanation. And this is just important because knowing that if you do have problems getting pregnant, you should seek out help. They have not really been able to say, though, that this is specifically caused by Ehlers-Danlos syndrome, but it does seem that these women may have a higher risk than the general population of having infertility issues. That risk in the general population is only about 10 to 15%, and again, in this population, it's 44%. So how have we been doing as providers taking care of women with Ehlers-Danlos syndrome? Again, this was from the same survey, and they asked women if they were ever told by a healthcare provider not to conceive because of their condition of Ehlers-Danlos syndrome. And about 23% of women were actually told not to conceive. In vascular EDF, which we're going to talk about the details of in a little bit, they were, say, 65% of the time told not to conceive. And interestingly, this is a common thing that I think sometimes healthcare providers will hear Ehlers-Danlos syndrome and then just sometimes they can be dismissive of it, or they can be overly cautious and telling women that they should not conceive because of this condition. Again, I think it's a very individualized conversation with the person. And in a majority of cases, women can have very healthy and successful pregnancies. This was the graph in the lower right is something that I wanted to talk about as well, because in that earlier slide, we talked about all the different ways that people can become parents. And unfortunately, it seems like in this survey, a lot of the healthcare providers did not really talk about the other options as much with the women. And just knowing that, you know, if you are told that you should not have a pregnancy because it is a high risk to you, first I would ensure that that was correct. And if that is truly correct after seeing subspecialists, then there's lots of other options that are potentially available to you to have a pregnancy. So to just spend a minute talking about vascular EDF, I think they're sort of the exception to all of this. These women have a much higher risk in pregnancy, potentially related to the cardiovascular changes and hormonal changes in pregnancy. And I think this is one where it is really important to discuss those risks of pregnancy prior to getting pregnant. The risks have been described as women can have arterial dissection in pregnancy. Mortality, we think there's a range, but about like 10 to 15% is the most recent estimates. They can have preterm birth and premature rupture of membranes, potentially uterine rupture, or hollow organ rupture. Despite this risk of mortality in pregnancy, we do know that there was a study where they looked at women who had pregnancies and didn't, and there wasn't actually a difference in overall survival. So it may be that women potentially could pass away during pregnancy with vascular EDF syndrome, but it's not necessarily specific to pregnancy. So just going back and talking now about all different types of Ehlers-Danlos syndrome, we don't really have a lot of information for the rarer types, because we discussed that there's about 13 different types of EDF. But in the more common types, type 1, 2, 3, and then 4, we know that the risks are mainly with preterm birth and preterm rupture of membranes, so that the water breaks early around the baby. Those rates have been quoted as about 20%, and we think that the highest risk is if the baby has the same condition, because from the genetics, the baby will be in charge of that membrane, and the membrane that surrounds the baby has collagen and different connective tissue proteins in it, and it won't be as strong if that child is also affected with the same condition. We know that women with EDS have precipitous and fast labors potentially. It's been described that women have a decreased resistance to local anesthetics, which is really important when talking to the anesthesiologist, and there may be a higher risk for postpartum hemorrhage. So we're going to discuss some of the plans that you should talk about if you have Ehlers-Danlos syndrome and you're wanting to have a pregnancy. The main tenets are to plan ahead, assemble your team, and then we'll talk about some of the things we do during pregnancy to have optimal care. So plan ahead. This is talking about making plans with your doctor prior to having a pregnancy. So there are some medications that are important to get off of prior to pregnancy. Some women that have aortic disease or different things will be on some medicines that are not safe in pregnancy. One of those is an angiotensin receptor blocker. That is something we want women to be off at least 6 weeks prior to getting pregnant. There are other medications that people can be on, and they may want to have discussions about coming off of those prior to pregnancy, such as NSAIDs like ibuprofen. And if you take any kind of pain medications, you may want to talk to your doctor about trying to modify that regimen prior to becoming pregnant. Imaging studies are important prior to pregnancy, where we want every single woman that has Ehlers-Danlos syndrome to have some type of baseline imaging of their heart and aorta, just to make sure that everything is okay. Additionally, spinal imaging is something we want if somebody has any scoliosis or any other problems, just so that we can ensure that the anesthesiologist can best take care of them if need be. A lot of these conditions are autosomal dominant. And with that, genetic counseling is important, and talking about genetic testing options. For type 3 or hypermobile EDS, there's not yet been a gene described, although we know this has a genetic component. And in order to do testing in a baby, you need to know that ahead of time. So for the hypermobile types, we're not able to do any kind of genetic testing for the baby in pregnancy. But for other types, if women have a known genetic change, then we can look for that same change in the baby during pregnancy if they want. There are no studies, but there is some theoretical concern about doing genetic testing during pregnancy. If the membranes are weaker, potentially there might be a higher risk of the membranes rupturing during something like an amniocentesis, where you take a needle to take some of the fluid from around the baby. However, there haven't been large studies to say that this is true. Talking about counseling, it is important to meet with a provider again ahead of time, just to talk about you as an individual and the obstetric risks in pregnancy, any type of risks to your joints or pain, and then any cardiovascular risks. In terms of pregnancy, this is something we want to do in a planned fashion. So if you are not actively trying to get pregnant, it's important to just discuss contraceptive options with your provider. So there's a whole team that takes care of women who have Ehlers-Danlos syndrome in pregnancy. Most of the time, this team will include at least a consultation from a maternal-fetal medicine specialist if they're available, an anesthesiologist to see you ahead of time. Potentially the neonatology or the baby doctors will be involved. During prenatal care, if need be, having a pain specialist involved in your care, physical therapist, and then nurses, of course, from all the subspecialties. In the cases where women have known cardiovascular problem from their EDS, a cardiologist and cardiovascular surgeon should be involved. And for those, it's important they deliver at a hospital with cardiothoracic surgery available. So in terms of the management principles for women with EDS during pregnancy, one of the main tenets is protection of the joints and joint health. We talked about relaxin, which is a hormone made during pregnancy, which is important for making the body and the pelvis able to birth a baby. However, this is loosening joints, and then joints can become less stable. I talk to my patients about doing physical therapy, even if they haven't done it in the past, and working with a physical therapist that understands what Ehlers-Danlos is to help strengthen the joints in a very gentle way, and giving people exercises to help with joint health during pregnancy. There's also pregnancy belts and braces that are available if the pubic symphysis starts to separate, which is the pelvic bone, which is a fixed joint, but then can sometimes start to come apart and cause severe pain in some women. So with the joints, it's really important just to work with physical therapy, potentially have bracing, and then just the way that you move is really important as well, that you take time standing up and realize while you're pregnant that your joints are much more flexible and loose than your baseline, and sort of taking care when you're changing position or moving that you don't move too quickly and potentially dislocate something. Some women have issues with postural orthostatic tachycardia syndrome, which is where if you move suddenly, you can have lightheadedness, dizziness, and a fast heart rate. This is something that can be diagnosed with the help of a cardiologist, and the main tenets of care are to have good hydration during pregnancy with good water and salt intake. Compression stockings can be helpful because during pregnancy, the blood can pool in the veins in the legs, and this can sort of help push that back up. And then in some cases, if needed, medications can be used. The ones that we think are the safest to use in pregnancy are beta blockers and midodrine. For women that have any kind of aorta or vascular involvement, it's important to have beta blockade during pregnancy, and this sort of helps decrease stress on the blood vessel walls. Also, the echocardiogram is just an ultrasound to look at the aorta, and then we can also look at different parts of the vascular tree with an MRI, which is safe in pregnancy. The frequency of this will depend on how severe the disease is. Usually it's every trimester, and if it's very mild, it could just be, once in the pregnancy. In terms of pain management, a lot of women will have chronic musculoskeletal or joint pain coming into pregnancy. And I think this is, again, something that you work with someone on an individual basis. If somebody is using opioids to help them with their chronic pain management, I think prior to pregnancy, it's important to sit down with them and try to figure out sort of the lowest doses or some alternatives in some cases. Opioids are things that cross the placenta, and the baby will have exposure to the opioids. In some cases, women cannot get off of those medications, and that's okay as well. And we try to just work with women to, have their pain tolerable but get on the least amount of opioids if at all possible. As I discussed before, NSAIDs like ibuprofen are things that we can't take in pregnancy because that can potentially cause something to close in the baby's heart that later when they're born, it needs to close properly. It can leave them with this problem called a patent ductus arteriosus. So we don't want to have NSAIDs in the pregnancy. We also want to work with pain specialists during pregnancy because, as we talked about, the joints are going to become more loose and women actually may have more pain during pregnancy. One study talked about with women with hypermobile EDF that about 26% of them had worse symptoms during pregnancy and 37% had worse symptoms postpartum. So it is important to sort of work on maintaining good pain control during pregnancy. Also, there's alternative medicines that can be used as an adjunctive to pain medicines with acupuncture, massage, and sometimes some types of yoga or just very gentle physical therapy or Pilates can help. So the anesthesiologist is a really important person as well during pregnancy. We discussed that prior to pregnancy, we'd really like people to have spinal imaging with either a CT scan or an MRI to know about scoliosis, dural ectasias, which are shown in the lower right corner, where you can have outpouchings in the spinal coverings. And really, this is just a problem in that if the medicines, like an epidural or the regional anesthesia is put into the spine, the medicine can pool in there and not work as well. In very, very rare cases, there could be vascular problems or, and that is something that we definitely would not want to, or we would want to avoid during the regional anesthesia. With regional anesthesia, why is this important? So everyone does not have to have the epidural or spinal. The reason we like to have this for women, especially those who have any kind of cardiovascular problems or aortic dilation going into pregnancy, is that pain in labor can actually cause high blood pressures, high heart rates, which puts much more stress on the blood vessels. And so for that reason, it's protective of the cardiovascular system to have this, the spinal or the epidural. And so it's really important for women that have the cardiac problems, but otherwise, this is something that just we would want to have as an option, especially if a woman had to have a C-section. So meeting with that anesthesiologist, regardless of whether you want to have the spinal or epidural, is important just for planning for emergency situations. The other things that's important is to talk to them, or we make sure that the anesthesiologists know that women can have resistance to local anesthetics with Ehlers-Danlos syndrome. Most of the time, though, the anesthetics, when they're put into the spinal canal, do work well for women. They just may need to have more medicine available, and that's why it's important to think about epidural versus a spinal. So the epidural, there's a catheter that can deliver that medicine continuously, versus the spinal, they just shoot the medicine in and then it works once. It's important for women that have TMJ to also let the anesthesiologist know about that, because it's been described that they may have a difficult airway, which would be important to know about ahead of time. And then for all women, sort of keeping an eye on their blood counts during pregnancy, because some women can become anemic, and potentially cross-matching them for blood prior to delivery, because there's an increased risk potentially of postpartum hemorrhage or having increased bleeding in the postpartum period or right after delivery. So what are the delivery recommendations for women? For most types of Ehlers-Danlos syndrome, vaginal delivery is the method of choice to deliver, even if there's concerns about dislocations. Most of the time, just we can keep careful positioning during delivery, and women are able to have a vaginal delivery. We reserve C-section for obstetrical indications. If they need to have surgery or there is concerns for a vaginal tear, it's important to pay special attention to those tissues with the type of sutures used, and just care knowing that the tissues are more fragile. We think the timing of delivery should be around 39 to 40 weeks. For vascular Ehlers-Danlos syndrome, it's a little bit different in that those women are recommended to have cesarean deliveries, and we do it a little bit earlier, around 34 to 37 weeks. The reason we do this is because we know that women can potentially rupture the uterus when they're in labor, and additionally, if they do deliver vaginally and have a tear, it can cause a lot of problems, and it's very, very difficult to repair. And so those women are recommended to have cesarean deliveries planned, and if they go into labor, they still should really have a cesarean delivery if possible. There have been case reports described about using DDAVP to help with that increased risk of bleeding, and really, though, there's been no large trials that have said that this is important, and this is not something that's generally recommended for women. Additionally, there are new studies just for the general population with postpartum hemorrhage using tranexamic acid, and this is not something that's generally used for all women. After delivery, it's important to ensure that women are recovering well and that their joints are doing okay, to continue with physical therapy exercises, as some of the joint symptoms can become worse. For women that have any cardiovascular problems, it's important to manage them and potentially look at their aorta and vascular system prior to them going home, and then follow them postpartum. Women that have the cardiovascular problems, there's been stuff in the literature about breastfeeding and how this is potentially putting women at higher risk for aortic dissection. There is good data about this in mouse models. However, in women or in human beings, we just don't really have that data yet. And so I think, you know, until we get human data, we really can't be telling women, or we don't tell women yet to just not breastfeed. But if you do have cardiovascular problems and Ehlers-Danlos syndrome, or aortic root dilation and Ehlers-Danlos syndrome, then you should be followed closely in the postpartum period if you are breastfeeding. So just a summary note in the end is, I talked about a lot of different problems of like preterm birth and joint problems and all of these different things, but really I can tell you that I've taken care of lots and lots of women with Ehlers-Danlos syndrome, and a majority of them can have really healthy and successful pregnancies. And it is important just to have a provider that you really trust and work with, and they will work with you to get you through that pregnancy. The summary points that I just wanted to talk about are planning ahead. See your obstetrician or care provider or midwife before you get pregnant. Make sure you have a good plan going into pregnancy, and then assemble that team that works for you to have everybody help you have a really successful and good experience in pregnancy, and then make sure that you get care throughout your pregnancy. I think the best resources for information are the Ehlers-Danlos Society. They have such wonderful resources, and y'all are very much aware of that because this is all through this wonderful foundation, and I wanted to thank them for allowing me to speak. I put my email up here if anybody has any questions, and I'll be available for the live discussion to answer your questions. I also put my email up here for questions afterwards. And I just wanted to thank you for this amazing opportunity, and I hope everyone is doing well. Thank you.